Hi, this is Brian Kim. I'm going to share with you this case of a patient who needs a toric IOL. I'm going to show you my technique and how I position the lens. So I have the patient sitting upright in the pre-op area, and I mark the horizontal position as well as inferior, 3, 6, and 9 o'clock. Intraoperatively, I don't do any marks. I don't do any marks because it smudges on the cornea or it can be quite inaccurate. And so what I like to do is go ahead and take the cataract out. When it's time to position the lens, I go ahead and bring the axis ring on, see where I need to place it, and then use a Maltzman or a second instrument to manipulate the eye either counterclockwise or clockwise, and ensuring that I have full inflation of the capsular bag with continuous irrigation. And by doing it this way, I can position the lens exactly where I want to. I don't have to worry about all the smudging of the ink or the mark. And then I'm able to position it by, again, inflating the eye and being able to very carefully and easily and safely manipulate the lens into position. And once the lens is in position, I come out, which basically locks in the position of the lens, and finish up the case. So you can see this is the left eye. I have 6, 3, and 9 o'clock marked, which was done while the patient was upright in the pre-op area. I'm using my cotton tip to center the eye, and I'm using a corneal marker to help me center and size from my rhexis. I'm holding the eye again and turning it so that I can have a flat approach with my paracentesis incision, first superiorly, which is on the right side, and then inferiorly, which is on the left side here. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic to inflate the anterior chamber. I'm using a cannula to hold the eye, turn it for me for my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then enter. And that's the triplanar corneal incision using the cannula to help manipulate the eye. I'm going to begin my puncture style Capsulorhexis. I'm going to puncture centrally, pull downward towards me, grab on the right side to create a flap. I'm being very careful because where I start the flap is going to determine the diameter of the rhexis, and so you want to make sure that that is the appropriate size that you want. Going around circumferentially, grabbing and re-grabbing every few clock hours, making sure my teeth are parallel to the iris plane. And then I burp some viscoelastic at the end. And this is my capsular fornix hydrodissection technique. I'm going to place the cannula underneath the capsulorhexis edge on the contralateral side, point the tip down, get a nice fluid wave, decompress on the left side, and the lens spins on the right side. And this is the start of the phaco. I'm going to start some irrigation of the cornea first, position my tip sleeve appropriately, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. We'll start to remove the surface epinuclear material, which enables me to create a little epinuclear ridge or shelf. I'm able to place my chopper underneath the epinuclear ridge, which ensures I'm in the capsular bag. I turn the phaco tip vertically, subincisionally. I bring both instruments together, and I'm able to crush the lens in half. Place the chopper out to the contralateral equator, pull it centrally toward the phaco tip, which crushes and divides the right heminucleus in half. I lift that first quadrant with some vacuum, and you can see the lens piece is just kind of falling apart and emulsifying fairly easily there with vacuum. I place the chopper out around the second quadrant, pulling it up out of the bag, and then crushing it with mechanical fracturing forces, and then using high vacuum to emulsify the lens pieces. I'm going to turn the second heminucleus in front of me, place the chopper around the lens, place the phaco tip deep, sandwiching and crushing and dividing the heminucleus in half, using vacuum to remove that third quadrant very easily, and then getting around the lens piece around the fourth quadrant, pulling it centrally, and then using high vacuum to remove the fourth quadrant pieces. Now it's a very soft lens and begin to start removing the epinuchal material, which prolapses out of the bag with a high vacuum. I'm placing the chopper deep to make sure I can protect the posterior capsule from the phacotip. Okay, take the chopper out, push BSS in, take the phacotip out, and then replace it with the INA handpiece. I'm starting subincisionally, grabbing the anterior aspect of the cortex, sweeping side to side to loosen it, and then pulling it up. I'm going around circumferentially in the same manner. Again, the polymer tip and the high vacuum and aspiration really allow me to have a very efficient removal of the cortex. I switch to the polish mode and start polishing underneath the anterior capsulorhexis edge. I want to make sure that there's no remnants of any lens material. This is a pretty big bag, big eye, big chamber. And using the polish mode in this situation is a good idea. The zonules tend to be a little stretchy with these types of eyes. So I'm polishing on the posterior capsule surface now. Again, I'm able to do that confidently because of the polymer tip, which is very safe. I'm pushing BSS. I'm going to be pulsing the BSS into the subincisional capsular fornix, which is nice and clean. And then I'm injecting some cohesive viscoelastic to inflate the capsular bag. I'm using my capsule sweep now to polish underneath the anterior capsulorhexis edge. First on the left side. And then on the right side. So I'm going to inject the single piece acrylic toric intraocular lens into the capsular bag. And while it's unfolding, I go in with the INA. Once I'm in, I activate irrigation, disengage the leading haptic and then trailing haptic off the optic, get underneath the optic, turn it and rotate it 90 degrees and remove all the viscoelastic within the bag. So at this point, we need to really start thinking about how we're going to position this toric lens. And I believe the lens is supposed to be at 75 degrees, 75 degrees. So I'm polishing underneath the anterior capsulorhexis edge because sometimes there's some very fine lens material that's still attached. Going underneath into the bag again as well, making sure it's nice and clean. So I'm removing all the viscoelastic from the anterior chamber now. And this is really where we're going to start thinking about lens positioning. In the past, when we were trained to position the lens implant, we were taught to do it with a second instrument with the eye deflated. But you can see the posterior capsule, the lens has basically been cocooned by the capsular bag. This is not really the proper way to position the lens. And yes, you can put viscoelastic in the eye, but then you have to remove the viscoelastic. And when you remove the viscoelastic, it's going to cause the lens to move position. So the key is remove all the viscoelastic first. Once all the viscoelastic is removed, you can go in with irrigation. It inflates the bag. Once the bag is completely inflated, you can use a second instrument, manipulate the lens position and the cylinder axis any which way. You can go clockwise, counterclockwise. It doesn't really matter. Why? The posterior capsule is pushed away from the lens. So when you manipulate the lens with the second instrument, this is a very, very safe maneuver. Okay, so let's get back to our case. There is continuous irrigation going on. All the viscoelastic has been removed. The eye is inflated. I'm using this Maltzman to position. I'm getting underneath the anterior capsulorhexis edge, and I'm turning that lens. You can see I turned that lens counterclockwise about 30 degrees. And now you can see the axis is really right at about 90 degrees. I did that just to show you that I can position the lens in a counterclockwise manner. So then I turned the lens back using the Maltzman and the INA handpiece, and you can see this is perfectly at 75 degrees now. The lens is at 75 degrees. Again, I didn't use any extra marks. I just positioned the lens, used the axis marker to confirm the position. Under continuous irrigation, I push BSS, take the INA handpiece out, and then I hydrate my incision. And this hopefully locks in the position of the lens where I wanted it to be. I start hydrating my incisions, and that's the end of the case. And so again, don't put viscoelastic in the bag, position the lens where you want it to be, and then you have to remove the viscoelastic. Removal of the viscoelastic will cause a sudden jolt and movement of the lens because the viscoelastic is going to get from within the bag up and out of the bag. It will push and manipulate the lens out of position. It really makes no sense to do it that way. Remove all the viscoelastic in the bag and in the anterior chamber first, and then under continuous irrigation, inflate the eye, which pushes the capsular bag back, and you can manipulate it with the second instrument. You can see now, again, I'm at 75 degrees, perfect position with this technique. This is really a very consistent way. I have never had to reposition a lens implant with this technique. Again, manipulating the lens under viscoelastic or even without viscoelastic will cause tension on the capsular bag and stretching of the capsular bag. And even though you think you're repositioning the lens, all you've done is just stretch the capsular bag and the lens is still in poor position. This way is really a fail-safe way to have a proper axis position. So I hope this was helpful to you, and I thank you for your attention.